So let's kind of briefly go over what we finished on last time. We talked about the adrenals. So we talked about the adrenal cortex as well as the adrenal medulla. Now, what's produced by the adrenal medulla? Good, epinephrine, norepinephrine, so fight and flight. And then the adrenal cortex is going to be subdivided into 3 different zones, right? So you got the one that's furthest towards the outside, the most superficial zone. That's the zona glomerulosa. That's going to be responsible for like salt balance. So you're going to see things like mineralocorticoids, aldosterone, right? So you're going to be able to reabsorb things like sodium. Then the level below that is the zona fasciculata, and that's going to be associated with stress hormones. So glucocorticoids. When you hear cortisol, you're always going to think like glucose release and stress, right? That's why it's going to be glucocorticoids, right? Glucose and cortisol. And then the zone below that is going to be zona reticularis, and that's going to be associated with sex hormones, and we're thinking like androgens, okay? So those are the major hormones in those regions. Make sure you know the names of those regions and what they're going to be implicated in, okay? Here's another summary of all those different areas on the adrenal cortex, as well as the adrenal medulla. Another image giving you a summary of those different hormones associated with those different regions of the cortex. And there's another good summary of that. So you have a lot of information there for you to make sure you commit all those regions to memory. Those are definitely going to be on your exam, so make sure you're familiar with all of those. When we talk about mineralocorticoids, we're thinking like minerals, right? Electrolytes, salts. And so one of the major things is going to be aldosterone, which is going to allow for a greater reabsorption of sodium. So in other words, if your fluid levels are really low and you need to like increase your blood pressure or your fluid levels, aldosterone comes in so that you can reabsorb sodium. And because water follows solutes, then you're going to also increase overall fluid volume. Okay? That's going to be the major component of mineralocorticoids and the zona glomerulosa, which is the outermost section. So this is the major thing here, reabsorption of sodium, and then of course water follows solute. So water is going to follow suit as well. Just talked about that. I already gave you the answer to that. Let's move on. Then you move down one level in the middle of that cortex. So the zona fasciculata, that's going to be cortisol release. And cortisol release is one of your primary stress hormones. Usually it's a good thing, right? If you want to increase your glucose levels, if you want to increase like stamina, energy, things like that, it's usually good. But it can become pathological, right? So chronic exposure to stress can be a really damaging thing. Chronic exposure to stress can throw off so many different elements of your physiology, resulting even in things like weight loss over time, chronic stress, anxiety, things like that. And then glucose in general, you don't want to have too much glucose in your system because glucose can cause severe amounts of damage to a lot of different parts of your body. We're especially going to focus on that when we talk about diabetes and the different regions that are affected when a patient has diabetes, i.e. uncontrolled blood sugar. But cortisol is going to be useful if you're in a situation like this guy over here. Unlucky man getting attacked there by a lion. But like I said, it's usually going to be associated with fight and flight, so that's going to be part of your stress response. But chronic amounts of stress are going to result in all sorts of downstream pathologies. So not good if it's chronic. So this is what happens when you have chronic stress. So you can get anxiety, you can even get depression. Generally speaking, when we talk about depression, usually it's going to be in combination with anxiety. It's kind of rare just to see depression 100% on its own. You can see that with like MDD, which is major depressive disorder. But generally speaking, you'll see depression coupled with anxiety. And there's several different types of anxiety. Some of the anxiety disorders that we could even consider as being the most severe types would be like post-traumatic stress disorder, right? And so patients with PTSD, they're going to have a lot of different issues with their physiology, particularly when it comes to falling asleep. they have a really hard time going to sleep, staying asleep. And then they'll have these crazy nightmares. They'll get teeth grinding and all sorts of stuff. That's all going to be a consequence of this elevated stress response, elevated cortisol release. That can also result in things like weight gain, right? So we just talked about sleep problems, especially if you think about PTSD patients, right? So post-traumatic stress disorder, they're going to get sleep disturbances. And you also might see weight gain with chronic stress levels. That could be associated with, for instance, like glucose levels. Glucose being really, really high in your body. You could see a little bit of weight gain as a consequence. And then memory and concentration impairment. Think about patients with PTSD. They're going to have a hard time focusing. They're going to have a hard time concentrating. So it really kind of throws off, the person's like mental stability. Too much stress. So this is a summary of the different hormones involved in cortisol release. So CRH, that's cortisol releasing hormone. When you see that R, think hypothalamus, right? It's either releasing or inhibiting hormones from the hypothalamus. And then you get the anterior pituitary releasing adenocorticotropin hormone. And then that's going to help to release cortisol from the zona fasciculata of the adrenal cortex. Move on. And then you move down to the innermost layer of the cortex, and that's when you're going to see the release of things like androgens, i.e., or example, testosterone is a good example of that. So those are going to be involved in a lot of different things, like primarily secondary sex characteristics, right? So like breast development, hair distribution, that's characteristic of the different genders, right? And then yes, also you can take endogenous androgens, which of course those endogenous androgens are going to be heavily regulated amongst athletes too. So, all right, then we go down into the adrenal medulla. So that's the innermost section. Now the adrenal medulla, norepinephrine, epinephrine. The majority of what's produced is going to be epinephrine. So about 75 to 80% of all the hormone produced by medulla is going to be epinephrine, and a smaller percentage is going to be produced, is going to be norepinephrine. You can also refer to them as adrenaline as well as noradrenaline, respectively. I'm going to bypass this. Oh, yeah, let's bypass that. And this is where we left off last time. So we did the quizzes for Chapter 17, Part 3. So let's start getting into newer material. We're briefly going to talk about the pineal gland. Why did I include this like crazy cool psychedelic art in the pineal gland? A, I like psychedelic art, but B, what's like the medical reason why? There's two hormones or two substances produced by the pineal gland, one of which is really heavily studied. You can even buy it over the counter at the grocery store. The other one, you can also buy it, but it's going to be on the black market. What's up? Melatonin, yeah. So melatonin is going to be heavily implicated in sleep-wake cycle, right? So it's going to help to balance your circadian rhythm. Circadian rhythm is going to tell you when to get up, right? For me, it's around like 12 o'clock in the afternoon. For some of you guys, it might be earlier than that. It's going to tell you what time to go to bed. It's going to also determine your metabolism, like, for instance, when you should eat your breakfast, when you should eat lunch, when you should eat dinner, when your body is going to be primed for different metabolic activities, like absorption of nutrients. So that's why they say you should maintain a regular sleep schedule. You should also try to maintain a regular eating schedule. I know some folks like to wake up in the middle of the night, like 3 in the morning, and have a snack. That's kind of unhealthy to do. My wife does that like all the time. So I tell her not to do that, but she still does. But yeah, so you want to make sure you maintain those like different regimens in your day because it helps to maintain a healthy metabolism. Another reason why shift workers that work at night, some of you guys might wind up doing that when you're working in the hospital, is like nighttime shift. Night shift workers have a really, really like difficult time balancing their circadian rhythm. And because of that imbalance, you also see other things happening downstream from that. Like a lot of nighttime shift workers tend to have like metabolic syndrome. They have like difficult time balancing their glucose levels. So that's a huge issue. So it's really good to try to make sure that you maintain a healthy sleep-wake cycle. And the second substance that's produced by the pineal gland is dimethyltryptamine, also known as DMT, which is also implicated in like dream-wake cycle. So both melatonin, dimethyltryptamine sort of kind of play similar roles in maintaining our sleep-wake cycle, as well as circadian rhythm. So kind of interesting. Cool. We already basically talked about all that. Oh yeah, by the way, the location. So this is a sagittal view of the brain, okay? And so you have in the front, the more anterior portion of the diencephalon, you're going to have the hypothalamus, you're going to have the suprachiasmatic nucleus and the optic chiasm, and then you're going to have directly posterior to the optic chiasm, by the way, that's where cranial nerve 2 crosses, and then you're going to have directly behind that the pituitary gland. Then on the other side, on the most superior portion of the brainstem, you're going to find the pineal gland. And that's the gland that produces melatonin as well as dimethyltryptamine. So some other things that melatonin do, this is kind of an interesting side effect of melatonin. It helps to reduce oxidative stress. Oxidative stress is going to be a result of free oxygen species, so reactive oxygen species, or free radicals, sorry. And those can cause a lot of damage to things like lipid membranes, can cause damage in other parts of your body. So melatonin is going to actually help to sort of reduce the effects of that type of oxidative stress. And then circadian rhythm, if you're thinking SAD, do you guys know what SAD stands for? Yeah, seasonal affective disorder. I had that pretty bad when I was living up in Portland, Oregon, because it gets dark at like 3 in the afternoon and it kind of sucks. I barely ever saw the sunlight, and I was really feeling miserable because of seasonal affective disorder, because when it's dark all the time, that's basically signaling to your brain, hey, it's nighttime, let's start cranking out melatonin. Not very great when it's like 3 o'clock in the afternoon, right? You don't want to go to bed that early. It's not great. Cool. Oh yeah, and by the way, melatonin levels will eventually start dipping as you age. That's why older people tend to have a more difficult time, A, falling asleep, and B, staying asleep, right? A lot of older people sometimes have to go on sleep meds, for example, like trazodone, things like that. Help them go to bed and stay in bed. All right. Anyone know why I put Patrick Swayze and Luciano Pavarotti over there? They died from pancreatic cancer. Exactly. Yeah, they both died from pancreatic cancer. Lots of famous people have died from pancreatic cancer. Really, really brutal diagnosis. Let's just get into it. So here's the pancreas. It's going to have these little ports that are going to allow pancreatic enzymes to enter into the duodenum. There's a lot of different things that are produced by the pancreas. There's both endocrine as well as exocrine function. In terms of exocrine function, you're going to have a bunch of different enzymes that are released by the pancreas. Can anybody like name a couple enzymes produced by the pancreas? Okay, so there's a few. Amylase is one. Amylase is produced by the pancreas as well as your salivary glands. When you chew a piece of bread, right, if you keep it in your mouth long enough, it'll start tasting sweet. That's because amylase is going to break down large, complex carbohydrates, and it's going to break them down into like individual tiny monomer sugars, right? And those sugars are going to taste sweet. That's why when you chew on bread for a while, it turns kind of sweet. Amylase is also released by the pancreas. So the pancreas, whenever you eat a large carbohydrate meal, like I just had a big thing of pasta, my pancreas is probably like going into high gear right now, releasing amylase to break down those complex carbohydrates. Another one that's going to be released by the pancreas is lipase. You guys know what lipase might do? Break down fats, exactly. Lipids, so lipase breaks down fats. Protease is also going to be released by the pancreas. Protease, what does that break down? Proteins, yeah, it's all kind of in the name. Amylase is the only weird one. Lipase and protease, pretty straightforward. So those are some like examples of like the exocrine function of the pancreas. Now in terms of the endocrine function of the pancreas is going to release 2 major hormones. One, take a guess. You guys know? Insulin, awesome. What's the other one? Glucagon, good. and they have opposite effects on each other, right? Insulin is going to be when there's a lot of blood sugar, right? Your glucose levels are high, insulin gets released, then your cells can start bringing glucose into the cell. And then glucagon does the opposite. If your glucose levels are low, when glucose is gone, right, then your pancreas allows for glycogen to start getting broken down so that you can have elevation in glucose levels, right? Glycogens can be found both in the liver as well as in their skeletal muscle, predominantly. And then in terms of the regions that you should be familiar with in the pancreas, there's going to be the islets of Langerhans. And we're going to talk about what those do in a second here. Oh, and by the way, beta cells and alpha cells. Which one goes to which? Which one goes to glucose or glucagon? Which one goes to insulin? Beta cells are insulin, right? And then alpha cells are glucagon. Okay, pretty straightforward. Nothing too crazy. This is just a recap of endocrine versus exocrine function. Just remember that when you hear endocrine, you think that hormones are going to be released into the bloodstream, and it's going to be communicating with other target tissues and target organs far away from the origin, right? Far away from the actual gland itself. Whereas with exocrine function, you're going to have the release of substances through ducts, usually to the surface. For instance, you have like apocrine glands in your skin that release different substances. So those are going to be examples of like exocrine type function. So exocrines may or may not have ducts. And then another thing, this target gland is going to be far away from endocrine, like the original endocrine gland that secretes. Whereas with exocrine function, usually the target's going to be a little bit closer in proximity. And here are some examples of each. So we already talked about a lot of these, right? Thyroid gland, pituitary gland, adrenals. And then on the other hand, you have like salivary glands, right? That are, secrete different substances. Lysozyme, for instance, is something that's going to be released by the salivary glands. Do you guys know what lysozyme does? Anyone in here take microbiology? No. When you guys do, because that's going to be one of your classes, lysozyme is produced by your salivary glands, and it attacks gram-positive bacteria. It breaks down the cell wall of the bacteria. That's what lysozyme does. And that's something you find in saliva. Sweat glands are another example of exocrine type function. So, cool. Let's talk about the difference between insulin and glucagon in a little bit more detail. So you guys pretty much nailed it. Whereas insofar as insulin is secreted by beta cells versus glucagon, which is secreted by alpha cells. When glucagon is released, it's going to be targeting liver, adipose tissue, and it's going to help to increase the amount of glucose in your blood. And then beta cells, obviously, is going to be the opposite, right? Beta cells releasing insulin, it's going to reduce those glucose levels in your blood. So let's talk about the islets of Langerhans. The islets of Langerhans are going to be the little regions in the pancreatic tissue that results where you find beta cells and alpha cells. And by the way, when I was talking about Patrick Swayze and Luciano Pavarotti, they both had pancreatic cancer. Here's a question. This is a kind of a side note, but it's kind of good to know. If you have cancer of your pancreas. Let's go back to the image of the pancreas. So the pancreas is going to be subdivided into the head of the pancreas, body, and tail. Okay? So the different regions of the pancreas. And the head is where you're going to see not only bile coming in from like the common bile duct, from gallbladder, liver, you're also going to see other ducts where you have pancreatic enzymes entering into the duodenum. The duodenum, if you guys recall, is going to be the most proximal portion of your small intestines. Stomach, pyloric sphincter, pylorus, and then into the duodenum. Okay? If you have pancreatic cancer, where would it be worse? Would it be worse to get pancreatic cancer on the head or on the tail of the pancreas? The head? If I raise a hand, who thinks it's the head? It's the worst place to get the pancreatic cancer. Who thinks the tail? Who thinks the tail? Anyone want to volunteer tail? You want to volunteer tail? Do you want to take a guess why? No? If you had pancreatic cancer somewhere here, where would you have pancreatic cancer where you would first start actually seeing symptoms? Head or tail? Flip of the coin. Heads. That's where you would first start seeing symptoms. What happens when you start getting symptoms of something? You go see a doctor, right? You go to the hospital. You're like, all right, what's going on with me? So in other words, when you get pancreatic cancer of the head of the pancreas, it's way better because you go to the doctors first before it spreads, before it metastasizes, before it advances. If you get pancreatic cancer in the tail of the pancreas, that's called a silent killer. By the time you're symptomatic, it's too late. It's already destroyed your pancreas. It's probably already metastasized, gotten to the point of like stage 4 cancer. And now you're terminal, right? So if you are to get pancreatic cancer, you would hope that you would get pancreatic cancer on the head. You don't want pancreatic cancer, I'd imagine, but if you did get it, that'd be the better place to get it. That's a huge digression, but I think it's important just, what's up? Because right here, that's where you have the different ducts releasing enzymes, releasing bile out into the duodenum. Once you start getting blockage of any of these ducts due to like a tumor, right, then you're going to have all sorts of downstream consequences. You might start getting pancreatitis or leaking of those pancreatic enzymes, which start to digest itself. You ever heard of pancreatitis before? So pancreatitis, usually a result of alcoholism. There's other things that can cause pancreatitis too. But if you have leaking of amylase, lipase, protease, and it's not going in this proper location, it's like digesting the pancreas, it's really painful and it's like severely symptomatic. So that's why if you get it in the head, you get those symptoms up front much more rapidly than you would if it's on the tail. Make sense? Cool. What's up? Heartburn. Heartburn is usually going to be associated with like excessive amounts of hydrochloric acid produced, right? So heartburn would not necessarily be a subsequent result in terms of symptoms. You get more heartburn if you had, well, lots of different things. Too much acidic production. That's why you take things like omeprazole, which is a proton pump inhibitor. So that would reduce the amount of like hydrochloric acid being produced. Like symptoms of heartburn could also be due to like reflux, like GERD, gastroesophageal reflux disease. So you wouldn't really see heartburn. When you have anything involving the pancreas, it is a very sharp, like a knife. People complain about it like a knife stabbing into their abdomen. Sometimes it's periumbilical, but mostly it's going to be hypergastric or epigastric pain. So it's going to be like above the umbilicus. That's where all the pain's going to be. Extremely painful. And then it radiates to the back as well. So really nasty. You're not really going to get heartburn. You're going to get more of like a stabbing pain. Very sharp. Cool. All right. So moving on from that, let's move on to, oh, here we go. So a good thing, we're going to talk about this later, but there's going to be antagonistic effects of hormones, right? When they antagonize each other, they have opposite effects, right? So glucagon is going to have an opposite effect of insulin. That's an important concept to keep in mind. And then we're going to talk about some examples of like additive effects a little bit later in this chapter as well. So we'll go into those like interactions between hormones. If you have any issues with insulin production or insulin sensitivity, that's when you start getting into the realm of diabetes. But let's just talk about the function of insulin in and of itself. So insulin, beta cells, right? Insulin is going to increase glucose uptake, right? So it's going to reduce the amount of glucose that's free in your circulatory system. It's also going to help enhance ATP production, right? As soon as like glucose comes in, if you guys recall, and have you guys studied aerobic respiration? Where you have like glycolysis, then you have the citric acid cycle, aka the Krebs cycle, aka the TCA cycle. I don't know why the hell they named it 3 different things. Then it goes on to the electron transport chain, right? But you start with a glucose molecule, right? Glucose molecule gets broken down, turns into pyruvate, acetyl-CoA, and all that stuff. So glucose is going to help produce ATP, right? Once you get into that, especially in the mitochondria, when you get into aerobic respiration, electron transport chain, you get a lot of ATP produced from one single glucose molecule. You also see stimulation of triglyceride formation, and then glycogen formation. So glycogen is going to be one of those highly branched storage molecules, right? That's going to be used in case of need. So glycogen is also going to be formed as a result of insulin, and that's going to be stored in both the liver and the muscle. Now, glucagon, opposite effect, right? So it's going to help use up energy reserves because glucose is gone. So now you're going to have to go into those reserves, like glycogen, for instance. You're going to go into glycogen, break down that glycogen so you can free up those glucose molecules. It's going to break down triglycerides, right? And then you're going to have stimulation of glucose in the liver. So pretty straightforward stuff. It's just opposite effects from each other. And here's just a summary of what that looks like, both the positive and the negative feedback loop. So that's just there for you to go through, see the different processing of glucose versus glucagon versus insulin. Here's another example of that. So to not beat a dead horse here, let's move on. So let's talk about diabetes. Diabetes is one of the worst and most difficult diseases to manage, both diabetes type 1 and 2. When I was doing my primary care, family medicine, clinicals and whatnot, this is like something I would see all the time, right? You see lots of patients that have uncontrolled blood sugar. You can do a series of different tests, which we're going to talk about in a little bit. You can do a fasting glucose. You can do a random glucose test. And then you can also do another test. You guys know it off the top of your head? Have you heard of some of these tests? There's one that can monitor long-term sugar control. Have you guys ever heard of the hemoglobin A1C test? Yeah, so hemoglobin A1C is really good because you can monitor or you can get an estimate of like the average glucose control over a period of about 120 days. Why 120 days with hemoglobin A1C? Where do you find hemoglobin? In your red blood cell. How long does a red blood cell live? 120 days. Good. So red blood cell lives for 120 days. Hemoglobin A1C is associated with the red blood cell. So that being said, if you monitor the A1C of a patient, you can monitor their glucose control for 120 days. And if it's above 6.5, that's going to be elevated. That's going to be indicative of diabetes. Another good thing about the A1C test that we're going to talk about a little bit later, if you have a patient that comes in, they know they're going to see the doctor, like, oh, I'm going to go see the doctor tomorrow. I better eat my veggies today. I'm not going to eat any sweets. So they go into the next day. Their fasting blood glucose is good. It's like below 100. Everything's cool and fine. But then you take the hemoglobin A1C and it's like 9 or 10 or even higher than that. So you know that the person basically just did like a little bit of a fast just because they knew that they're going to come see you. But you could actually get a better reading of their actual glucose control over a greater span of time with the hemoglobin A1C. So you can see if they're like cheating on their diet or not just cheating on their diet, if their medications aren't working. Sometimes you have to adjust the meds, right? So, oh yeah, and then the reason why I include these really awful images is because like diabetic foot ulcers are going to be very common amongst these patients. Why? Why do you see that? Why do you see diabetic foot ulcers? Yeah, exactly. And it's a double whammy too. So she said correctly that it's because you get nerve damage, right? So diabetics get peripheral neuropathy. That's a very common side effect of diabetes. But you also get damage to capillary beds because if you think about glucose, it's just causing all sorts of chaos and damage to like vessels and things like that. Think about it as like little shards of glass going in there and destroying everything that they come in contact with. You also get poor vascularization. So you can also get if you get an injury, it's going to take longer for it to heal because you're not getting enough blood to that region, right? And so as a consequence, a lot of patients get an injury. They don't know it because they don't feel it, right? And all of a sudden it gets infected. And then what happens when you get an infection on your foot? Oftentimes the patient gets osteomyelitis. What's like the gold standard treatment for osteomyelitis? First of all, what is osteomyelitis? Have you guys heard of that term before? Osteomyelitis is an infection of the bone. It's very difficult to treat. Usually the gold standard treatment is this. You just cut it right off. You cut off the damaged tissue. You can give antibiotics too, but usually you have to do an amputation. And that's why over a long period of time, diabetics tend to get shorter. It's a really bad joke that one of my colleagues, he's a podiatrist and he works with a lot of diabetic patients. And I asked him, so how do you like your job? He's like, it's great. I make people shorter. That's a really dark joke. Anyways, moving on. These are all the other areas of your body that can get affected by too much sugar, right? You can get retinopathy, so you can get all sorts of stuff happening to your eyes. Diabetes is going to be a really common cause of blindness. Can cause renal damage, right? You can go into like renal failure. A lot of your dialysis patients, they have long-standing uncontrolled diabetes and hypertension too for renal failure. Neuropathy, we just talked about that. Peripheral neuropathy is going to be very common, where you don't feel, you have like, numbness and tingling, mostly numbness. You have things like stroke, right? Those are going to be common side effects of diabetes. And then obviously if you have a stroke, you're going to be cognitively impaired, depending on the severity of the stroke. Heart, blood pressure is going to be affected. You get coronary artery disease. And then poor wound healing and ulcerations. It's going to be very common themes with diabetes. So diabetes is not a joke. It's a very, very serious disease. And it's very difficult to control, unfortunately. Now, diabetes type 1 and type 2. Let's go into the details about that. With diabetes type 1, you're born with it. Okay? So it's going to be something that you're born with. It's going to affect younger people. Usually, when a patient gets diagnosed with diabetes type 1, they go into what we call DKA, diabetic ketoacidosis. I know a lot of people that they didn't know they had diabetes type 1 until all of a sudden they went to DKA and they had to get hospitalized, at which point they found out that their glucose was like 600, 700, really, really, really high levels. And then it's going to be considered insulin dependent. So insulin dependent. That means that it's an inability for your beta cells to actually produce insulin. What happens is that it's immunologically mediated. So you have antibodies going in, attacking those beta islet cells, thinking that it's like a foreign invader. It destroys those cells, and now all of a sudden your pancreas can't create insulin whatsoever. So it's an autoimmune disease. And key factor here, skinny. A lot of these patients that have diabetes type 1 are going to be very skinny, right? Because they're not even able to process glucose. So they can eat food, the glucose goes into their system, they get rid of it. So the glucose is not being absorbed in their body. And this is actually a problem for some people too, especially for younger patients that want to be like skinny. Sometimes a patient with diabetes type 1 will actually not take their insulin because they notice that if they don't take their insulin, they lose weight. So kind of not a good situation. Better ways to lose weight than not taking your insulin. And then there's diabetes type 2. That's going to be adult onset. It's usually going to be associated with diet. There are other things that can cause it too. Like, for instance, you can get diabetes from, metabolic syndrome. There's certain drugs that can cause that as well. But mostly we're talking diet, so really poor diet, lots of like carbs, things like that, sugar. So generally speaking, these patients are going to be obese. And then what happens is that it could either be one of two things. Either their cells become insensitive to insulin, right? There's so much insulin swamping their body that the cells are just like, I don't know, I'm not going to deal with you anymore. And so they become insulin insensitive, or their pancreas could basically become exhausted from having to crank out so much insulin that you basically have like failure of those beta islet cells and they stop producing insulin. That's another reason why not just metformin, because metformin is like one of the common diabetic drugs for diabetes type 2. Sometimes these diabetic patients, after a long period of time, are also going to have to start taking insulin as well because their pancreas is no longer producing insulin whatsoever. These are some of the symptoms, right? You get hyperglycemia. You get hyperglycemia in both. Sorry, hold on a second. Let's talk about hypoglycemia versus hyperglycemia. If you're hypoglycemic, you have no sugar in your body, right? And then you're going to start getting some like altered mental status. You can start getting sweats, headaches, dizziness, etc. Very, very dangerous. You want to make sure that you have sugar in your bloodstream. Otherwise, you can actually go easily into coma and death as a consequence. Then hyperglycemia, where you have sugar levels like above 300, These are the 3 P's. So polyuria. What does that mean? It means that you're peeing a lot. What about these other 2? What's polydipsia? Do you guys know what that means? Thirsty. Yeah, you're really, really thirsty. What about polyphagia? Huh? Polyphagia? Yeah, well, think about phagocytosis for cells, right? That's like where a cell goes in and gobbles up another thing, right? So polyphagia means you're eating a lot. You become really hungry. So those are going to be the 3 P's of hyperglycemia. So this is how you diagnose. These are 3 different ways you could do it. You could do a fasting glucose. That's going to be the most common thing. Whenever you general checkups, you're going to usually tell your patient, hey, don't eat anything the morning of, don't drink coffee, don't eat a breakfast. Just come in, make sure that you haven't eaten in 8 hours, and that's going to be your fasting. Generally speaking, if it's under 100, that means normal. If it's 100 to 125, pre-diabetic. If it's over 126, on two consecutive visits, that means that the patient can now be diagnosed with diabetes. Now, if you did a random glucose level, aka they probably ate breakfast or whatever, they just did their regular thing, and if it's above 200, that means you can also diagnose them with diabetes. And then the hemoglobin A1C, that's going to be the really good one that you can track their glucose control for a longer period of time. And if it's above 6.5, that's going to mean diabetes. Okay? Pretty straightforward. By the way, you should keep these figures in mind, all right? I'm going to include these on your exam. I'm going to test you on this stuff. All right, so diabetes type 1, autoimmune disorder. We already sort of talked about this, but basically what's happening is that your own body is like freaking out. It thinks that the beta islet cells are foreign invaders. They go in there, they wipe those cells out, and now you can no longer produce insulin. And that's why this is called insulin-dependent diabetes, diabetes type 1. Diabetes type 2, it's going to be insulin independent. It's going to either be due to insulin receptor insensitivity throughout your body, or it's going to be to burnout of your pancreatic cells, right? Your beta islet cells are like, can't do it anymore, exhausted, so they stop producing insulin. Watch a little video on this.
Type 2 diabetes is a condition in which your blood sugar level is too high. Carbohydrates are substances your body uses to...
All right, that's going to put me to sleep. I'm going to skip that. You guys can watch that on your own time. But I think it just basically reiterates everything I just talked about. So moving forward. So type 2 diabetes, you have sugar in your body, but insulin resistance. In other words, your cells aren't able to actually take up glucose levels, or glucose in your bloodstream. So your glucose levels remain high. And that's basically what happens. Let's talk about different forms of diabetes. So there's gestational diabetes. This is a really unfortunate one, and it's pretty common. It happens to anywhere between 2 to 10% of pregnant women. This is what happens when a person has never had diabetic symptoms in the past, but all of a sudden, while they're pregnant, for some reason or another, the hormones during pregnancy are interfering with the ability for insulin to do their thing, right? So in other words, the mom is going to have elevated levels of glucose in her bloodstream. And so that's going to be considered gestational diabetes. And you can treat it with a couple of different ways, just, augmenting the patient's diet. Maybe you can try to encourage them to do a little bit more exercise. But effectively what it has to do is those hormones from pregnancy, from the placenta, are interfering with insulin. That's kind of like the basic gist. Now, if you have too much glucose during pregnancy, that means the baby is getting way too much sugar. They're getting way too many nutrients. And then you have a condition called macrosomia. And macrosomia basically is just a big baby. So, as a consequence of gestational diabetes. And then there's diabetes insipidus. And this is a little bit different. So diabetes insipidus is going to predominantly be associated with the hypothalamus. And it's not able to produce antidiuretic hormone. Okay? So if you don't have antidiuretic hormone, what does antidiuretic hormone do? You guys remember? Does it make you pee more or does it make you pee less? It makes you pee antidiuretic. Yeah, so you're not doing any diuresis, so you're peeing less. So if you don't have antidiuretic hormone, that means you're going to be peeing more, right? So a patient that has diabetes insipidus, it's going to be associated with the hypothalamus and pituitary not producing and releasing antidiuretic hormones. So the patient is going to have excessive amounts of urination, and they're going to also be excessively thirsty. So they're going to have polydipsia, so dehydration, usually as a result of a tumor or trauma. So if you have like a traumatic brain injury that causes any damage to your hypothalamus or your posterior pituitary, right? Because remember, your posterior pituitary is where you have storage of antidiuretic hormone along with oxytocin. So, cool. Let's talk a little bit about growth hormone. So this is going to be sort of like a recap of what we talked about over the past week and a half here. Andre the Giant, huge dude, wrestler, also actor. He did a lot of really cool things. I'm going to show you a funny video with him. He's a pretty wild man. So he had acromegaly, and it's associated with growth hormone, right? So if you have growth hormone, especially post-puberty, if you have too much growth hormone, it's going to cause a condition called acromegaly. And so what happens with growth hormone is that it's going to be affecting both skeletal muscle as well as bones. And when it does that, you're basically just have a lot of excess amounts of growth, right? That's what growth hormone does. Pretty straightforward stuff. It also does cause fats to get broken down, and those fats are going to be used for like for energy, right? So here's a silly question, but I'm going to ask it to you anyways. What's going to happen if you have too much growth hormone in your body? What's going to happen to GHRH levels? Up or down? If you have too much growth hormone? So if you have too much growth hormone in your body, then you're going to have a reduction of GHRH, right? Because growth hormone, releasing hormone, it's going to basically say, oh, there's too much of this in the system right now. So it's going to be like a negative feedback loop. So you're going to have a reduction in GHRH levels because of that. So there's going to be a couple different pathologies associated with growth hormone, and these are the three major ones we're going to talk about. So we're going to talk about gigantism, we're going to talk about acromegaly, and then we're going to talk about dwarfism. There's two major categories of dwarfism, and I'm going to talk about them later on. But one is going to be proportional dwarfism, and the other one's going to be disproportional dwarfism. Proportional means that the person is actually fully symmetrical, right? Their head is symmetrical to the rest of their body. Disproportional is going to be associated with a condition called achondroplasia, and that's going to involve the ability for bones to growth in the cartilaginous regions of the bone. Okay, so that's going to be different than what you see with dwarfism associated with growth hormones, a different process. But still, they're going to have short stature, just different presentation. And I've included this image. It's a very famous image. If you Google search other images that show like the progression of a person who gets acromegaly, there's a lot of really interesting images. So this lady, she looked very, very normal when she was younger, and all of a sudden you start seeing how like she had like enlargement of her jaws. So you have like enlargement of skeleton as well as muscles, right? It happens to men and women alike. So pretty interesting stuff. Now, the thing that's different between acromegaly and gigantism is this: puberty. After puberty, it's going to be considered acromegaly. Before puberty, it's going to be called gigantism. Okay? So we'll go into those details in a bit here. So you're mostly dealing with long bones in your body. Okay? And usually what's going to happen, it's involving some form of pituitary type tumor. All right? So it's going to excessively release growth hormone from the pituitary. Actually, wait, did I miss something? I want to show you a video of this dude. Well, anyways, so this guy over here, we talked about him day one of class, right? So that's Robert Wadlow. He was the tallest dude, 8'11", absolutely huge. I mean, that's like wild. He's like double the size of a lot of people. Today, the tallest living man is this guy right here. He's based out of Turkey, so that's kind of interesting. And he's only 8'1", so he's almost an entire foot shorter than Robert. The thing about him, though, is that he's still alive. Robert Wadlow, if you recall, he died at 22 years old. He was just a little bit too tall. So let's watch a video about this. It's very, very fascinating. Wow.
Robert Wanda of Chicago, the ripe old age of 70, and they keep foraging in his house. And it is quite beyond the reach of young women. Every time young Robert goes through a doorway, he scores a duck. And this is Robert's father, a near dwarf of 6 feet.
Yeah, that's just totally wild. Super cool. All right. Lost my place here. Oh, there we go. Cool. So gigantism. Now, if you remember, gigantism, that's before puberty. All right. So this kid, 12 years old. All right. Look at the size of him. He's huge. Way bigger than his mom. 6'5" at 12 years old. And it's all due to growth hormone oversecretion, generally due to a pituitary tumor. Andre the Giant. This is that famous wrestler, also actor. 7'4", huge. Just really, really big dude. Legendary because of his wrestling abilities, also acting, but also I found this really fun video about his penchant for alcoholism.
The stories about Andre's drinking are almost another level of mythology from the man himself. Andre was certainly, one of, if not the greatest drinker that ever lived.
I myself saw him almost every night drink 7,000 calories worth of alcohol. Say 20 to 25 beers, maybe 4 bottles of wine, usually several mixed drinks.
Brother, I was with him on every drink. Andre was a big drinker at the match. Most wrestlers would not really have a six-pack. Andre, the minimum that he would ever have.
Like the wine. You have them bring in a case to start the day. A case of wine.
All this other now, when it's time to go to bed, throw some yellow beer, Andre. The manager of the hotel said, "What are you going to do?" Call AAA. That's all I can tell you. I was there. I wasn't there for the drinking. I was there.
All right, we all get the picture, right? Party animal. So Andre the Giant did not have gigantism. What did he have instead? Acromegaly. Yeah, so he had acromegaly, so a little bit different. So as opposed to, what's his name? Robert Wadlow. So Robert Wadlow, that's gigantism. Andre the Giant was acromegaly. So a little bit different. So this is what acromegaly looks like. You can actually see kind of like that disproportionate growth of bones, right? So look at that jaw, that mandible. That's huge, absolutely massive. Really crazy. You also see like overgrowth of those large bones too. So that's all going to be falling under acromegaly. Now the reason why it's important to distinguish this between gigantism is because gigantism is pre-puberty, right? During puberty, that's when you have the sealing and the closing of the epiphyseal plates, right? After that, if you start getting excessive amounts of growth hormone being secreted, then that's going to start turning into acromegaly, okay? Because you already have that sealing of those epiphyseal plates. Cool. And so this is that same guy that's in the previous image here on the bottom left there. That's the same dude that's right up here, Richard Dawson Keel. This was a James Bond movie, I think back in the 70s. This was that movie with, God, what's his name? Adam Sandler. What movie was that? Where he goes golfing? Happy Gilmore. Yeah. So this is a scene from that dude in Happy Gilmore. I like his T-shirt. That's kind of funny. This part right here is the funny part. I kill people. Andre the Giant. Obviously, we just talked about. What's up? Pituitary tumors. I mean, yeah, I don't know. You saw that Robert Wadlow video where he was standing next to his dad. His dad was tall, 6 foot tall, but way shorter, right? So these are going to be pituitary tumors. Albeit tumors can have a genetic underlying component to it. I don't know if these have a genetic component to them. So I don't think they do. Now let's talk about the opposite, right? So you have too little growth hormones. So that's going to result in dwarfism. So Peter Dinklage from Game of Thrones, that's what he has. So he has proportional dwarfism. That means like his whole body just looks like it would if he were taller, right? But he's just got short stature. It's also going to be associated with growth hormone, right? But you have undersecretion of growth hormone. So let's talk about the difference between disproportionate versus proportionate dwarfism. I'm not going to test you on this, achondroplasia. If I remember, well, you guys do skeletal for the first portion of this class, right? So you guys already kind of went over that. So we're not going to talk about that. But achondroplasia would result in disproportionate dwarfism. It's going to be associated with this gene right here, the FGFR3 gene mutation. And so basically you just have endochondral bone inhibition. It's not really growing properly. Versus proportionate dwarfism, that's when you have just hyposecretion of growth hormone. So nothing too crazy there in terms of differences. So let's go over a summary of a bunch of different hormones that we're going to cover as well throughout the semester, right? Especially when we start getting to like GI, when we get into renal. We're going to talk about all these different hormones in greater detail. But in GI, ghrelin is going to be one of the big ones, right? So ghrelin, think about your tummy going grr when you're hungry. That's going to stimulate appetite. Leptin is going to do the opposite of ghrelin. Leptin is going to indicate that, oh, wow, you're overfed. We don't need to eat anymore, okay? So that's going to be how they balance each other out. That's going to be their interactions. Kidneys, we're going to talk about later on, calcitriol, as well as that renin-angiotensin system. So that's a whole different complex system to maintain fluid balance, right? So if your fluids drop, maybe you're hemorrhaging or something like that, then the renin-angiotensin system will actually kick into high gear so it can try to maintain your blood pressure if you become hypovolemic, as an example. Heart, similar thing, except the opposite, right? If you have too much fluid, then that's when atrial natriuretic peptide comes in, so you can start secreting sodium so you can reduce your blood volume. Thymosins, we're going to talk about later, that stimulates T cells, right? Because T cell lymphocytes are what are going to help fight off infections, viruses, even like cancer cells are going to be associated with T cell lymphocytes. But that's where T cells go to mature, and it's going to be due to this hormone, thymosins. And then gonads, associated with all different types of sex hormones. So let's go into these in a little bit more detail. We're going to go over these much more in the future as well. But the kidneys, we're thinking calcitriol as well as erythropoietin. Erythropoietin, of course, you can have endogenous erythropoietin to stimulate red blood cell production, but you can also do blood doping, right? So if you have exogenous erythropoietin, right, that's what they test for like competitive cyclists, competitive athletes. If they see that you've been blood doping with exogenous erythropoietin, that can be grounds for like being removed from the game or whatever. But at the end of the day, what erythropoietin does, it increases the production of red blood cells. And then we're going to talk about the renin-angiotensin system later, where it increases blood pressure. Heart, you have your natriuretic peptides that help to release sodium, right? So you reduce your overall fluid levels, you reduce blood pressure. It's going to be opposed to the renin-angiotensin-aldosterone syndrome. What the renin-angiotensin-aldosterone system does, it helps to try to increase your blood volume, increase blood pressure. So these are going to work in opposite effects. We just talked about thymosins and T cell lymphocytes. The testes, we're going to go into a great deal about that when we get into the reproductive section, but androgens are going to be the major class of sex hormones that are associated with testosterone. You're also going to see inhibin as being one of the hormones released. That's going to be associated with the maturation of sperm. So we're going to talk about those later on. And then estradiol as one of the major estrogens. A lot of these hormones for the ovulation cycle are going to be associated with the corpus luteum. And so during the ovulatory cycle, once the egg gets released, right, then the remaining portion within the ovary is going to turn into the corpus luteum. It just translates to yellow body because it's kind of yellowish in color. The corpus luteum is going to release progesterone. Progesterone, progestation, right? So it's going to help promote the implantation of the egg into the endometrial lining, right? And it's going to help to maintain the endometrial lining during the entire gestation of a fetus. And then prolactin, we already talked about prolactin already. And then we just discussed leptin, but leptin is going to be associated with, oh, I had too much food, no longer hungry. If you have like anorexia or bulimia, right, you have like very, very low BMI, right? So you're like sickly thin at that point. It's going to affect a lot of different things, right? You're going to have some hormone imbalances, but you're also going to see amenorrhea. I know of ballet dancers who had really strict teachers, ballet teachers, and they said, if you're having a period, that means you're not dancing hard enough. Because ballerinas obviously are going to have a very strict kind of like weight, I don't know what you'd call it, weight expectations, I guess. And so a lot of ballerinas tend to be very thin, and oftentimes being really thin is going to mess up with the rest of your hormone balance. And so oftentimes you'll see amenorrhea, which means you're not undergoing proper menstruation cycle. And because of that, if you're really young and prepubescent, then you're not going to properly undergo puberty at the right time. So you're going to have delayed puberty if you're really, really thin. So let's talk a little bit about the way that hormones interact with each other, right? We kind of already discussed some of like the antagonistic type ways, right? So you have one that operates in one way, like insulin, and something that operates in the opposite direction, like glucagon, right? So it's going to be a delicate balance between the two. So insulin and glucagon, that's going to be good examples of antagonistic effects, right? Other ones are going to be calcitonin and PTH, right? Calcitonin maintains the tone of calcium in your blood, right? So reduces calcium. Parathyroid hormone on the opposite end of the spectrum is going to increase the levels of calcium in your blood. Then you also have synergistic or additive effects between hormones. So ADH, antidiuretic hormone, as well as aldosterone are both going to help increase the level of fluid volume in your body, right? Antidiuretic hormone, you're no longer going to pee, right? So it's like vasopressin is a good example of that. Aldosterone is going to bring sodium back in through reabsorption in the kidneys. Water follows solutes. Now you're increasing your blood volume, okay? PTH and calcitriol. So calcitriol is going to be a hormone released by the kidneys to go to the GI tract to absorb calcium into your body from your diet, okay? So we're going to talk about calcitriol later when we get into the renal system as well as the GI system. So PTH increases calcium, reabsorption, and so does calcitriol, increases calcium levels. We already talked about atrionatriuretic peptide, etc. So we already talked about all these. I'm going to fast forward. So let's go over all these in more detail, and then we will close out with some questions. So we already talked about growth hormone with like gigantism, acromegaly, as well as dwarfism. Growth hormone is going to help to also maintain glucose concentrations. Thyroid hormone, we already talked about it quite a bit ad nauseum. It's going to be implicated in a lot of different things. If you have hyperthyroidism, too much thyroid hormone, you're going to get like excessive heat, weight loss, anxiety. Opposite for hypothyroid, cold intolerance, weight gain, lethargy. If you don't get enough concentration as you're developing, you might develop cretinism, right? That's going to be congenital hypothyroidism. If you don't get it before puberty, you might get poor development of your skeletal system. Parathyroid hormone, we talked about that in relation to calcium, right? So parathyroid hormone is going to increase calcium, right? And then, let's see here. What else do you need to know? Reproductive hormones, let's move forward. Cool. As we age, so hormones can change, right? what we talked about with like thyroid hormone, right? So if you don't have too much thyroid hormone as you're developing, you might get cretinism, which is going to affect your mental ability. A lot of these hormones are going to affect all sorts of different elements of your physiology, right? We talked about cortisol levels being way too high. Cortisol levels can eventually result in things like anxiety, depression, stress, weight gain, and memory issues. So long story short, you want to make sure that you balance out all your hormones to maintain homeostasis. As we get older, our hormonal balances change, right? Women will go into menopause, so they're not producing like estrogen properly, in regular amounts. So those are some things that can happen if you have hormone imbalance, and that can happen over time. So let's close out with talking about general adaptation syndrome that was basically coined by Hans Seile. I don't know how to pronounce that last name. Does anybody know how to pronounce that? I don't know what the origin is of that. It's like maybe Swedish or something. But anyways, there's going to be 3 stages of general adaptation syndrome. The first stage is going to be just kind of like the initial onset acute alarm reaction. That's going to be an alarm to a stimulus. You're getting chased by a lion, right? So that's going to be the very first stage. The second stage is going to be over a very long period of time. It starts becoming more chronic. And then over that period of time of chronicity, then you're going to have a little bit of resistance to those hormones. And then at the very end is when you're going to have actual exhaustion and you're going to have collapse of that hormonal system. Okay, so let's go through these in the different stages. So the first stage is going to be that alarm reaction. You're this unfortunate fellow walking through the savannah, and you start getting chased by a lion. This is going to be the very first fight and flight response, right? It's acute, it's immediate, it's not bad for you, right? It's a necessary physiological response, so you can get away from an adversary or a sticky type situation. So very short term, it's going to be involved in the sympathetic nervous system, right? So epinephrine, norepinephrine. Then the second stage is going to be that stage of resistance. It's going to be heavily involved in cortisol release, right? So cortisol release over a long period of time is going to start like increasing your glucose levels, right? You don't want to have elevated glucose levels for too long, otherwise it's going to start causing some serious issues elsewhere. And then you can also start seeing things like imbalance of other hormones like aldosterone and ADH. So you might start seeing excessive retention of water, excessive reabsorption of sodium. And then the very final stage is going to be that stage of exhaustion, and that's when you see like a total and complete collapse of the entire system. And at that point, you might start seeing the failure of other organ systems involved as well. So that's kind of the 3 major stages of general adaptation syndrome, GAS. Cool. Treatment, well, I guess just to avoid stressful situations, right? So you can try to remove the stressor, and you can try to encourage the person if they're not running away from a lion all the time. If it's other things causing stress, you can try to encourage them to engage in other activities that can reduce stress, things like meditation, aromatherapy, etc. But that's basically it. Do you guys have any questions? No? No questions? What's up? Definitely know the basics. Like, it's an example like what? Oh, like the heart with like atrial natriuretic peptide and all that. Yeah, you should have a general. Yeah, and we're going to go over those, like especially when we focus on like the GI module and stuff. For the sake of this first test, we're going to be doing endocrine as well as blood. So I'm going to be testing you especially very heavily on the hypothalamus, pituitary, and then the organ, right? So if it's like the thyroid, parathyroid, the adrenals, those are going to be really heavily tested on. You should know them. You should know them. But yeah, I don't know if I've mentioned this before, but whatever I test you guys on, it's going to be stuff from the lecture slides, from my quizzes, and the things I talk about. So I'm not going to test you. If there's something like a minutia, a little detail that's in your textbook, I'm not going to test you on that. I'm only going to test you on stuff that I exposed you to previously in lecture. What's up? These? Oh, you should be able to access these on your computer, like if you go to the link. So you should be able to have that. So you can have that as your to like helps supplement your studies. Any other questions? Okay, cool. Let's do quizzes. I have 9 questions. Right now it's 4:07. Dang it. So we only have about like 12 minutes left. So let's get into it. If we don't finish this today, then we will continue where we left off on Tuesday at the start of class, okay? So let's go ahead and log in. Do a head count. 5, 6, 8, 9, 10, counted 55. Good job, guys. I think there's 55 kids in this class. I didn't mean to call you kids. 55 students in this class. So looks like all of you are here today. I'm very impressed. Hopefully it stays that way. All right, 2 more. 1 more. All right, let's do it. One of my classes told me that background music for quizzes makes them feel anxious. Do you guys feel the same way? It's pretty hilarious. All right, good job. Most of you guys got that right. So that's a second messenger, right? So you have a ligand attaching to the receptor. All of a sudden you have that downstream cascade of different intracellular responses, and cyclic AMP is going to be one of the major components of that. All right, next. All right, so T4. What does T4 do? T4 is your thyroid hormone, right? So one of the things that thyroid hormone does is that it's going to help to increase the amount of ATP. So it's going to actually have effect in the mitochondria within the cell. So in other words, it's going to go into the cell. It's going to affect the mitochondria. Testosterone is going to be, activating. Well, it's going to be undergoing transcription and translation directly in the DNA of the nucleus. Epinephrine is going to bind to an external receptor, and it's going to result in a physiological change within the cell. So epinephrine, fight and flight, think like you have like pupillary dilation, vasoconstriction. Your heart muscles start to pump really rapidly. Your bronchioles and your lungs dilate. So those are all going to be effects of epinephrine. Oh man, the music stopped. Can you guys see the whole question on your side? Yeah? Okay, good. All right, so the patient had a pituitary tumor, right? Oh, what in the world? Acute response view. Oh, this sucks. Okay, so let's see. Low, high, high. Um, this is like a new thing I tried to do like 3. I tried to do a different version of it where you mix and match, but it was for a premium account. I didn't want to have to pay for quizzes to do it. Okay, so let's just go through it. So if you have a pituitary tumor, it's like hypersecreting, right? Hypersecreting what hormone? TSH, right. Thyroid stimulating hormone is being hypersecreted. So that means you have really high TSH, which means what does your T3, T4 levels look like? Up or down? High. What about your hypothalamus? Low. Good. Pretty straightforward. Nothing too crazy. Does that make sense for everyone? Good. I'm going to have to figure out those types of questions on quizzes. Hey, you know, the attempt is what mattered. It looks like almost everybody got this question correct. So, yep. So I went pretty easy on you on that one. So insulin, right? The guy has a really high level of glucose. Very simple solution, insulin. Another easy one. Wow. Okay. Yeah, so beta islet cells, that's what produces insulin. Good job. Way too easy on you. Okay, I'm going to start going harder on you guys. And what region of the adrenal cortex is that? The zona what? What? Glomerulosa? Good, good. Good. So most of you guys got that correct. So aldosterone, so you're going to reabsorb sodium, right? So you can increase your fluid levels, sodium levels. We're not really doing anything with potassium with these hormones here. So that's good. 2 more. We actually might be able to get through all of them. Is that one also too easy? Way too easy. Bless you. All right, so key thing, right? He's prepubescent. Yeah, I mean, there are cases of younger individuals going through puberty at an early age, earlier than what you would expect. But that's very uncommon. So if you see something like 7-year-old boy, right, 7-year-old girl, too tall, you're thinking gigantism. All right, 2 more. Cool. Most of you guys got this correct. That's great. Would you get diabetes mellitus from a TBI? You guys know what a TBI is? Traumatic brain injury. That's a TBI. Would you get diabetes mellitus from a TBI? No, you definitely would not. Gestational diabetes from a traumatic brain injury. No. Diabetes insipidus. Okay. That's good. So you have, what happens with diabetes insipidus? What hormones implicated in that? ADH, okay, antidiuretic hormone. So they're not producing enough ADH, they're not, and then all of a sudden they have diuresis, right? They're peeing a lot. Let's do the last one, and then we can head out of here. Okay, pre-diabetic. No, so pre-diabetic would be what level? What's the threshold cutoff? 100 what? 125. So 125 is going to be the cutoff. 100 to 125 is pre-diabetes. Over 126, 2 consecutive visits. That's considered diabetes, okay? All right, good job, guys. If you have any questions over the weekend, just email me or shoot me a message.